So our next session is on RRRs for a novice strabismologist. So I would request Dr. Lakshmi C. She's a consultant at Abate Al Salama and pediatric ophthalmologist consultant, and to speak on right incision, limbal, fornis, or others.
So when we come to incisions in squint surgery, is it important to know what type of incision to choose? So before that, I would like to know if there are any postgraduates here in this room. Any postgraduates? Or yeah, at least 3 are there. Fine. So we think about 4 scenarios. What are the different types of conjunctival incisions? What are the advantages of these? And when do you opt for a particular incision? So you might have, all of you must be knowing that there are mainly 3 types of incisions. One is a limbal incision, the second is a Parkes cul-de-sac incision, and the third is a swan incision over the muscle insertion. And most commonly we use the limbal incision or the cul-de-sac or fornix based incision. And in certain scenarios we even go in for a minimally invasive strabismus surgery, which are basically modifications of the fornix based or the limbal incisions, and made in such a way that it can be converted into a limbal based or a fornix based incision if the necessity is there. So this is how a limbal incision is made. So there is a initially a conjunctival incision is made. First a nick is made at the limbus around 1.5 clock hours here, it's extended, and then we make wing shaped extensions for the limbal incision. This is the fornix incision, in which initially we need to rotate the globe. Suppose this is a medial rectus which we want to operate. We rotate the globe supratemporally, and then we identify the clear space between the medial rectus and the inferior rectus, a relatively white area, and we need to make the incision after tenting up the conjunctiva like so. Initial incision is made, and the second incision is made vertically in the tenons right down to the sclera to expose the bare sclera. So we get access to the medial rectus and the inferior rectus in this case. So this is how fornix incision is made. Limbal incision, we open up and directly we can hook out the muscle and proceed with the operation. In a fornix based incision, initially this has been described in Helveston. Most often we put it parallel to the lid margin. The incision is made approximately 8 mm from the limbus, and after doing the coming to the bare sclera after incising the tenons, the muscle is hooked like so, and the tenons above the muscle is reflected by another hook, and the sclera, the tenons here should be incised so that the superior pole of the muscle is also exposed. So we get a clean plane of incision. So these are the limbal and fornicial incisions. This is for obliques, for recti, and the limbal incision. So what are the advantages of each incision? Advantages and disadvantages. So fornix incision, the main advantage is the incised tissue. This is the rotated globe, and here is the incision that we make, and the incised tissue will slide behind the lid when you release the globe. So that will be masked by the lid, or it will not be seen outside. And it has a better appearance, a better plane of dissection, and there will be less of scarring. Suturing, most cases, will not be needed, and it is a better option if 2 adjacent muscles are being operated. And conjunctival recession may not be possible in such cases. If you are recessing the muscle and want to do a conjunctival recession, it may not be possible in a fornix based incision, but these are the advantages. The second thing is, coming to a limbal incision, we will get a very good exposure because we are incising the conjunctiva in a very large area, it needs very less assistance. Fornix based incision needs a better assistance and experienced assistance for good results, because otherwise your exposure will be very less. In a limbal incision, you get more of exposure. It needs suturing. Definitely it needs suturing. So the sutures will be visible in the palpebral fissure area. Whereas in a fornix based incision, it will slide back behind the lid. It has better option in re-surgeries. When we want to do an eye which has been operated earlier, this will be better because it is already a scarred conjunctiva and our planes may not be as clean as a first time surgery. So re-surgeries, better we have to opt for a limbal incision. We get good exposure. Conjunctival recession is possible in a limbal based incision. So when do you opt for, so I want the PGs to answer this question. You are operating, you are a squint surgeon, take it for granted, you are a squint surgeon. You are operating in an unfamiliar setup with a new assistant. What type of incision would you prefer? Limbal based because it is easier rather than going in for a fornix based. But ultimately it does depend on your comfort. If you are trained in one way, you tend to go in that way, and if you are trained in fornix based incision, you tend to go in that way. But in certain situations with an unfamiliar setup, it might be better to go in for a limbal incision. A high myope with exotropia who is constantly wearing a contact lens, he cannot move without a contact lens. You are doing surgery and they want to use the contact lens within the next few days. What type of incision would be better? For the contact lens fit, you want the limbus to be undisturbed. So which fornix incision would be better in such a situation? This is a consecutive exotropia case in which you are planning a medial rectus advancement with a lot of scarring expected. Which type of incision? It's a limbal incision because better exposure and you will not lose the muscle. Restrictive strabismus. In a which one? Can I get? Limbal. Why? The muscle will be very tight, good exposure is needed, and you might need to recess the conjunctiva in certain situations. So this is a recess resect procedure for an intermittent exotropia in a 6-year-old child, no other complications, routine surgery. In your regular OT, what incision would you prefer? Anything according to your convenience. You can take a fornix also because it won't be a problematic issue. It's a routine type of case. So thank you. So that's all about conjunctival incisions.
Thank you, Lakshmi, for the wonderful talk.
Now I request Dr. Saumya Nambiar to talk on the right anesthesia, local, general, and the workup of these anesthesia. Over to Dr. Saumya.
Thank you, ma'am.
Saumya is the consultant pediatric ophthalmologist in Contrast Eye Hospital. She did her fellowship in Shankar Netralaya, Chennai.
Thank you, ma'am, for that introduction. So basically, we being a pediatric ophthalmologist, we cannot go without an anesthetist. We have to have a teamwork and we need their help at every stages of our surgeries. So as a novice strabismologist, we need to decide what is the right anesthesia that we have to choose for our surgeries. And it differs, or the basis depends upon where you're working. Maybe a private institute or a private setup, or it may be an institute. So you have to decide. So basically, the various types of strabismus which we know are horizontal and oblique surgeries. So therefore, the type of anesthesia will depend upon what type of patient it is, what type of strabismus, and how many muscles you're going to tackle with, and is the surgery done for the first time, and the doctor and patient confidence level and the availability in your place. So the options of anesthesia is the local anesthesia. Local anesthesia, usually when you do, if suppose it is as a beginner, you have to start with a peribulbar block. You can do it in cases of unilateral cases, a simple RRR, a recession and resection. You can also do in bilateral cases, because if you don't have a GA setup, definitely you can opt for a local anesthesia. But definitely it's more time consuming for you as well as for the patient. He has to lie down comfortably. But before doing, rule out all high risk cases. Definitely, a cost factor can be reduced by giving a local anesthesia when compared to a general anesthesia, and you require minimal equipments. Most commonly what we use is lignocaine and bupivacaine. Problem is that complete echinacea is usually achieved, but sometimes when you pull the muscle, there may be some amount of discomfort whenever you do a local anesthesia as well. Then topical anesthesia you can do whenever you're planning a single muscle surgery. If you're planning to do a FDT or FGT, Botox injection if you're planning to give. And at the time of adjustment, like an adjustable you have done, you can give a topical if you have to do the adjustment. In minimal invasive strabismus surgery you can do. Basically it avoids the serious complications that are associated with GA. Now, topical anesthetic techniques, whenever we use, it's better to use that anesthetic, you soak that is you dip your vessel sponge, you dip it in the local anesthetic and keep there for some time instead of using the plain paracaine. So this is more beneficial than just putting a paracaine and then doing it. Suitable for surgery for medial and lateral rectus muscle. It should be avoided in other extraocular muscle, like you're planning an oblique surgeries and all, it will be difficult if you're doing it, and it will be uncomfortable to the patient as well. So general anesthesia is done in almost all pediatric cases, and if at all you're planning transposition, transplantation, looking for slip muscles, bilateral cases, oblique muscle surgeries, complex strabismus and repeat surgeries. So for this you need all these, you need the multiparameter, you need the ventilator setting, the flow meter settings, all these are the basic equipments that you will need for a GA. Then the prerequisites when you're doing a GA, a safe GA includes all this. That is, you need to have a preoperative assessment of the patient, evaluate the airway, you need to induce the patient, you need to secure the airway, maintenance and all that. With that you need a management of the pain and you need a recovery room. Okay, for a general anesthesia all this is required in an ideal anesthetic environment. And remember that all this has to be recorded. As you can see on the left side, you have a general anesthesia details. So this is how we follow. We have all the details, what has been done, patient name included, what type of anesthesia, what is the in time, what is the out time. This chart has to be maintained. Anytime there is a problem, this is what is first goes into the police records. So this has to be managed and documented. So in a pre-anesthetic checkup, what we do is we have to take the history completely and check up all the systemic conditions like respiratory, cardiac anomalies and syndromic patients. Malignant hypothermia is one thing which we are always scared of, but it has been found that in strabismus the risk is no longer there. So PAC can also be done in immediately before surgery. So in some centers we do not have an anesthetist, so we call them for a certain time and they do a PAC just before taking up the patient for surgery. But if the anesthetist is dissatisfied, telling that there is some problem with the oral cavity, the case is getting cancelled. You will have to explain the patient, you will have to explain the bystanders, and that is time consuming and also it is not monetarily also problematic for the patient. So these are the steps that we follow while giving anesthesia. In pediatric anesthesia, how is it different from adult anesthesia is, first you give an inhalational anesthesia and after that only you give an IV line, because the child is not going to cooperate for the IV line in the beginning. And this is how we maintain the anesthesia, that is the difference between LMA and endotracheal intubation. What is the difference? Most of the surgeons nowadays prefer a LMA, okay, that is the laryngeal mask airway. So basically what it is a supraglottic airway, okay, it is found to be safe, it is less traumatic to the patient, useful in difficult airways. When you are not able to put the tube, it is useful in this condition. And it's told that less anesthesia is required for relaxation. There's a shorter period of recovery time. While in case of endotracheal intubation, it goes through, the tube goes through the vocal cord, and therefore it requires a very good airway to put it. And this is usually used when you are planning for very long surgeries. And there will be reduced comfort level after the surgery. The patient will complain of sore throat and cough after that intubation. Though it is safe, it is definitely safe, but the shorter period of action, recovery time is little more longer. So complications that we usually dread in a strabismus surgery is the OCR, or oculocardiac reflex. So what is it defined as? Whenever there is a 20% decrease in heart rate from the baseline, or presence of arrhythmia which is induced by pressure on the globe or traction on extraocular muscles. This is how we get a OCR. So the OCR in strabismus surgery is as high as 86%, and as you can see in pediatric patients it's very high. So the symptoms are generally mild and transient in most patients. So what do you do if you have a OCR? So basically what you have to do is just immediately stop pulling the muscle, and that time it will give more time, prevent that OCR, and in cases you can also give atropine and glycopyrrolate, which tends to reduce this amount. And it's been seen that along with general anesthesia, if you give a little bit of local anesthesia, it prevents this. Now, during FDT, you have to see that saxamethonium interferes with interpretation of FDT. So always you can delay the force reduction test for about 20 minutes after injection. Okay, otherwise you may not get a good result. And nowadays, non-depolarizing muscle relaxant, like what we use, the atracurium, that is more beneficial for force reduction test. And therefore, on conclusion, the type of anesthesia varies with each patient and type of strabismus. Be mindful of patient's comfort and your comfort to adopt a safe practice, and documentation is definitely mandatory. Thank you.
Thank you, Dr. Soumya, for that wonderful talk on anesthesia, the basic principles.
Now I would like to invite Laila Mohan ma'am. She is the head of the department, pediatric ophthalmologist in Comtrust, Calicut. She is going to talk on the recession and resection. It's a video-based talk.
Thank you, Dr. Soumya. This is a very good revision for us, starting from basics, anesthesia, incision. And this is video-based. I'll just go when usually bilateral recession is done when there is a freely alternating ESO or EXO. You can see in this child fixing with the right eye. Now I close the, sorry. Okay, here the left eye is taking a fixation, but again goes back to esotropia when the cover is removed. So there is a dominance of one eye. So in these cases, you have to do treatment for amblyopia and then go for a, even if there is dominance of one eye, even after doing patching, then you may do a recess resection. Otherwise, it's better to do bilateral surgery, bilateral BMR, bilateral medial rectus recession. This is a bimedial recession if it is when it is done freely alternating. Actually, this is a very old video, and this is a Caputo's one snip paralimbal incision, little different from the, it's not limbal or fornix, but gives a small incision, and this is the pole test where you would like to separate the inferior and superior pole of the medial rectus and see that the whole muscle is with you. And after separating, then you hook the muscle, separate the tenons, and then respect the tenons. So once you, in larger recessions, you may have to go a little more behind. Otherwise, up to about 5 millimeters of recession, you need not go all the way back. So, but you have to make sure that you have separated the tenons well so that the muscle recedes well back. And the measurement is done before you, when the globe is not rotated, and make sure that the conjunctival or limbal fixation suture is not good. It is conjunctival now, and so it's not a very good bite from the limbus. So make sure that the tip of the needle is up, and you see the track of the needle all through the sclera, so that it is not quite deep. If you can't trace the needle track, that means you are quite deep. So that is to be made sure. And then you recess according to how much you want to recess the muscle. Nowadays, we don't use these cloth drapes. It's mainly disposable drapes. This is an old video, which... and make sure there is with a hook, make sure there is no attachments to the tenon, so that there is no further restriction of movement later. So now coming to resection, resection is always done after recession of a muscle so that the eyeball is better to handle, and the eyeball is not tight when you put a fixation suture. So you mark how much recession you want to do with the caliper, and then take the sutures. Don't go under the muscle, because if you go under the muscle there is a chance for slippage. So pass it through the muscle and then take it. You can take a thicker bite and then lock it. So the previous one was a double-armed suture where you can suture it with the two needles. Use a Prince forceps to hold the muscle and then cut the muscle. With the Caputo's incision, you don't have to dissect much when you do a primary surgery. As Dr. Lakshmi has rightly pointed out, when it is a resurgery or restrictive strabismus, or when you expect some difference from of the attachment and the restrictions of movement is there, it's always better to do a limbal. And fornix, you need more assistance. So that is a resection. So nowadays we go for, in primary cases, when we don't need any displacement, we go for plication of the muscle. This is a lateral rectus resection. Instead of resection, we are doing a plication of the muscle, where you take the bite as before, but after taking the bite from the muscle, you bring it using a spatula. Take a bite just in front of the insertion. And when you don't need any displacement of muscle, this is the surgery we opt for now. It has lot of advantages because you don't disinsert the muscle, you don't compromise vascularized circulation. So this is a better surgery, and immediately if you go in, you can adjust also. So remove the spatula. Spatula is just to hold the muscle and keep the plication throughout. And you can, in case you want a third bite, you can take in the middle also. We don't routinely do that. So she has already, Dr. Lakshmi has shown the fornix based incision has a, I'll just fast forward. When there is a good assistant to hold the conjunctiva back, you can do a fornix incision and then mark as before. I don't know why it is not moving. And mark it, and after suture, the main advantage is that as Dr. Lakshmi has shown, that the incision goes well under the lid and you need not even suture it. The conjunctival incision is very small. So I think I will just hit this. See, you need not even suture. So a hangback recession can be done when there's a small, especially in an adult, where you want to, you are not sure, 100% sure of the, because especially in an exotrope, you're even after patch test and you get a variable deviation, exotropia. You want to adjust the measurements even after surgery. And also when there is diplopia, you want to make adjustments if there is diplopia functionally. So then you do an adjustable, this is with the nose, and you can do a bow tie also, where you tie and then you remove the bow tie the next day under topical anesthesia, and then you do the suture. I usually use a black silk for the conjunctiva, so that after 5 days we can just remove it in the clinic. He need not come to the OP. So when there is a pattern with no oblique overaction, then you have to displace the muscle. So this is a upward displacement, where after section you mark the muscle, the deviation, how much you want to recess, and then displace the muscle full thick, one muscle with displacement is where you will take the bite of the inferior border. This is the inferior border, and then the next bite is taken after doing a measurement from the limbus, so that you make sure that the measurement is right. So these are some of the instruments which we use for very simple instruments. We don't have very high-tech instruments for strabismus surgery. Very simple surgery. Some surgical dosage always there in the textbooks, but you have to adjust according to your tightness or looseness, which from your own outcome you may have to adjust accordingly. Thank you.
Thank you, madam, for such wonderful videos. And I think basics is needed for all the novice strabismologists, very important to know at least RNR, recession and resection. So,
I want to add something. In every single case, it is always better to look for a force duction test before you start surgery, which I have not shown.
so next we move on to the next session, talk by Dr. Shabiba. Okay, she is a consultant in Agarwal Eye Hospital, Calicut. She'll talk on the right patient, the selection, and what consent has to be taken.
Thank you, Soumya Madam and the KSOS for the opportunity. As a novice strabismologist, I would share some of my thoughts regarding the right patient selection and consent. As we know, the common indications for strabismus surgery are either functional or reconstructive. Coming to the functional, our aim to create a comfortable single binocular vision and to enlarge the field of binocular vision, to relieve diplopia and to relieve the mechanical restriction. Coming to the reconstructive part, our aim to establish normal facial configuration by aligning the eyes rather than purely cosmetic. Coming to the selection of patients, it mainly depends upon two factors. First one, our surgical skill and previous surgical exposure, and second one, where we are working. If we are working in a tertiary care center, we have lots of referral patients and we can choose convenient cases according to our skill, and also our seniors will be there to guide us. But as a single strabismologist, we don't that advantage. We hardly get a convenient case to do. And factors which consider while choosing the cases. In the initial cases, we have to choose best outcome cases because it will slowly build up our confidence, then we will take more complicated cases. Horizontal rectal surgeries are easy to do and the calculations are more predictable. So we can take on horizontal rectal surgery as initial surgeries like alternating exotropia, IXT with consistent PBCT values and essential esotropia. And coming to the age of the patient, better to avoid initial surgery on infants because of anesthesia risk and also the strabismus measurement errors. And it is ideal to choose an adult patient with constant exotropia with amblyopia in that eye at the initial career. And the patient should be highly motivated, like those who want surgery before the marriage or before an interview, but plan surgery well in advance of their due dates of function. And don't take up confusing or complicated cases initially. And in our OPD, we have more complicated cases also, like children with any neurological disorders. In that case, there is chances of variable outcomes post-operatively, complex strabismus, second surgery, adult strabismus with diplopia, and variable strabismus. In that case, we have to keep that cases under follow-up if possible. And if we are confident enough to do that, then we can take it up later. And thorough preoperative evaluation is must in all cases before touching the patient or taking into the operation theatre. Repeat measurement of the strabismus at least 2 to 3 times between a gap of 2 to 4 weeks. And if a patient presented with esotropia, we have to rule out the accommodative component with proper cycloplegic refraction. And we have to give the classes according to the refraction, and again we have to check before taking the patient in case of partially accommodative esotropia. And in case of intermittent exotropia, we have to do patch test to rule out any pseudo-divergence. And if a patient presented with acute strabismus, usually we plan in that case surgery after 6 months only. And before taking the case for the surgery, we have to do imaging to rule out any neurological causes. and rule out any patterns or vertical strabismus associated with the horizontal deviation. And counseling is an important part. We have to clearly explain about the chances of success, and chances of reoperation is there about 5 to 10%, and chances of postoperative diplopia, and clearly explain that there is no effect on the visual status postoperatively, and the surgery is not the end for that treatment. Glasses or patching have to be continued to maintain the clarity of vision. And informed consent should be in the local language, a clear explanation of the rehabilitative nature of the strabismus surgery, educating the patients regarding intended benefits of improved and maintained stereo acuity, mainly in children, and as well as improving the ocular alignment, that is cosmetic purpose in adult patients. Discussing the appropriate expectation is key with patients who have diplopia, because it is important to explain the goal of increasing the field of single binocular vision rather than eliminating the diplopia in other cases. In addition, it is important to discuss that there may be change in the extraocular muscle function over time after the intervention, which could require an update of the level of prism in glasses or a second surgery. In all cases, we have to talk about the anesthesia risk also. As a novice strabismologist, this is my first case. This is a highly motivated 13-year-old girl with intermittent exotropia. After thorough orthoptic evaluation and ophthalmic evaluation, her best corrected visual acuity was 6/6 vision in both eyes with a mild, that is 0.5 cylinder in the right eye. I have done 3 PBCT measurements, and 2 before the surgery and 1 on the day of surgery, and her PBCT was constant. It was about 40 base in right eye for near and distant, and there is no pattern. I have done lateral rectus recession with a medial rectus plication. And postoperatively, patient has only mild exophoria with no diplopia, and patient is happy postoperatively. And take home message for today, we should take highly motivated patients, and the PBCT value should be consistent before the surgery. Choose a horizontal rectus surgery as first few cases, initial career, and pros and cons of surgery should be clearly explained in the local language. Thank you.
Thank you, Shabiba, for the wonderful talk. And I would like to say she was one of the best fellows in our Countess Hospital. And all the best for your future endeavors. Now I would like to invite Dr. Rashmi Bhaskar. She is a consultant pediatric ophthalmologist from Chaitanya Eye Hospital, Trivandrum. She will be talking on the right time when to do the strabismus, whether you have to do it early or late.
Thank you, Dr. Soumya, for giving me this opportunity. The right time for squint surgery, early or late? Actually, there is no right time, there is just time what you choose to do with it. There are certain factors determining the timing of surgery. We can classify them as ocular factors or general factors. They include the age of presentation. That is, sometimes they will come to you at 4 months of age, and some children will come to you only at 4 years of age after starting school and all. The type of squint, whether convergent or divergent, whether it is constant or intermittent. Angle of deviation, whether it is small or large. Duration of squinting, refractive error if any, and presence of amblyopia. And the general factors include how cooperative a child is for evaluation, developmental status and birth history of a child, systemic condition like cerebral palsy, Down syndrome, or any other anomalies associated, expertise of surgeon, whether they are capable enough of doing surgery in very young child, and safety factors associated with general anesthesia, as Dr. Soumya has detailed, and pediatric postoperative and ICU care. Because most of us will be working in an eye hospital, and it will be scenario will be different in case of a multi-specialty hospital. Each child is unique, and so is each case. So we'll see a few cases. Let us assume the case of an essential infantile esotropia. These are few cases that we operated the earliest. Let us see with a 4-month-old child coming with squinting, large angle squint with cross fixation, normal fundus and refraction. So what is the earliest possible age that surgery can be done for an infantile esotropia, and does the patient benefit from early surgery? Let's see what studies have to say. The researchers say that even in 1990, it was studied that the diagnosis of essential infantile esotropia can be made even up from 4 months of age. When the average axil length is more than 19 millimeters, that is in around at 4 months, that is sufficient for surgery. And Dr. Kenneth Wright has also established that high-grade stereo acuity can be attained by doing surgery at an early age. He himself has did surgery for his son who had an esotropy at a very early age, and he says that he has very good stereopsis and is a pilot now. And the study published in BJ also says that early surgery is beneficial to achieve binocular function, but the stable deviation measurement has to be done. In IJO, a meta-analysis was published regarding the timing of surgery in essential infantile esotropia, and they say that the critical period of sensory and motor development is 4 to 6 months of life. And they say that the children who underwent surgery in less than 7 months had a better stereopsis than those who underwent before 2 years of age. And the asymmetry in motion VEP was also more when the surgery was done in 11 to 18 months, and it was almost same as that of normal when the surgery was done less than 11 months. And abnormal and asymmetric OKN response was seen in children who underwent surgery in 11 to 18 months, and it was almost comparable to normal when the surgery was done less than 11 months of age. This is a case of essential infantile esotropia. So, who are the children who will benefit by early surgery? In the presence of persistence of esotropia between 10 weeks and 6 months, constant angle deviation of more than 40 prism diopters on 2 examination 2 to 4 weeks apart. There is no refractory error, that is less than 3 diopters, and absence of the following conditions: gestational age less than 34, birth weight less than 1.5, no history of any ventilator treatment, no history of any meningitis or developmental delay, no non-paralytic or concomitant squint, and manifest nystagmus. There should not be any manifest nystagmus, prior eye surgery, or presence of any structural ocular anomalies. Regarding the anesthesia concern, as per the gas study, they report that around 45 minutes to 1 hour exposure of GA has no adverse long-term effect in children, and the benefits of early correction outweighs the risk of anesthesia. So, what are the advantages of doing an early surgery in case of infantile esotropia? Better stereopsis and binocularity, reduced incidence of postoperative DVD and inferior oblique overaction, minimize the delay in sensory motor and motor development, and improve psychosocial and parental bonding. And the disadvantage is accurate estimation is difficult, and possibility of development of accommodative esotropy as sequelae. Coming to the late surgery advantage, you get an accurate measurement, and correction of the vertical misalignment can also be done in the same sitting, and the possibility of correcting amblyopia is also successful. And the disadvantage is increased incidence and severity of DVD and poorer gross and fine stereopsis and binocular vision. These are the inference that they gave after that meta-analysis. Coming to the next entity, which is the congenital exotropia, it is rarer than the infantile esotropia, onset before 6 months and large angle deviation. As per the study published in 28, the early versus late surgery for infantile exotropia, they say that the results of older age surgery, that is 2 to 4, has outcome comparable to the younger age. And they also say recommend the surgery after 1 year because their younger age was associated with reoperation and consecutive esotropia. Coming to the intermittent divergent squint that we see most often in our OP, the relationship between age and surgical results is always controversial. Most of them have good binocularity, but if they are overcorrected, they will lead to amblyopia. So let's see what the studies have they say. They say that the better motor alignment and sensory outcome are done when surgery is done less than 7 years. Younger age at onset and surgery were risk for developing recurrence in the larger case series as told by Kim et al. In International Journal of Ophthalmology, a study was published regarding the surgery at early age versus late. They found that a better long-term follow-up outcome when patients' surgery was done when younger than 4 years old. In a study in JAPOS, which was published in 2022, they compared the motor and sensory outcome. And when the surgery was done less than 5 years of age, they had a outcome of 84% success rate, and overcorrection was also 3% only. When the surgery was done above 4 years, they had a 68% outcome and a 8% of overcorrection. The conclusion, they found that the surgery at younger age was associated with higher success rate, but the risk of overcorrection can be minimized if you reduce the surgical dose. The indications we all know, it is increasing angle of deviation, deteriorating control, decrease in stereopsis and distance and near, and motor alignment. Advantages of early surgery for intermittent divergent squint is greater chance of bifoveal fusion, superior BSV, less chance of being constant, and better long-term results. While disadvantage is higher chance of overcorrection and amblyopia, and age affect the surgical dose effect response. The late surgery advantage, accurate evaluation is possible. Most of the cases they have intermittent divergence, have good stereopsis and binocularity, and so if you the chances of post-op overcorrection and amblyopia will be less if you correct lately. But the disadvantage is no restoration of binocularity, only motor alignment you will be able to achieve. In acute comitant esotropia and in case of paralytic squints, we all know that if the angles are stable for 6 months and if there are no treatable causes, the surgery can be done within from 6 months of age. And in case of congenital restrictive squints like Brown syndrome or Duane's, depending upon whether they are amblyopic and what is their alignment, how is their abnormal head posture, depending upon that, early surgery can be done. Better late than never. So any patient coming to you at the age of 50, 60 or 70, squint is a reconstructive and recreative surgery that improves the quality and clarity of vision. It's not a cosmetic surgery, and it's a right of each person to look straight. So take home message, in essential infantile esotropia, you can do surgery even as early as 6 months of age if other conditions are playing. An intermittent divergent squint, the ideal age is 4 to 7, acquired squint after 6 months and no upper age limit. Thank you.
Thank you, Dr. Rishmi, for that wonderful talk. Now I think we can have any points or questions anybody wants to ask.
Madam, how early you do surgery in infantile esotropia?
In fact, the measurement of angle of deviation is very difficult before 6 months. So I follow the PEDIC consensus, that is between 8 months to 18 months. And usually we don't see inferior oblique overaction. That is what we are looking for, vertical deviation, isn't it? Oblique overaction before 1.5 years. Usually, very, very occasionally I've seen them when you have to tackle the inferior oblique as well during this time. Usually it is the biomedial recession that is in essential esotropia. And we follow them up with the stereopsis, binocularity and stereopsis, and of course they have a central scotoma with central suppression, but fusion is good in many of these cases. And early, I would like to say vertical strabismus, especially MED and other types of vertical strabismus where you know you will have to do a second surgery, especially in a third nerve paralysis or a congenital paralytic squint where you need not just one surgery. I would like to do as early as possible, because you may need before the 4 years, that is the amblyogenic years, you would like to complete your alignment. So then I would like to start earlier than even essential esotropia.
Madam, essential infantile esotropia, if you are doing an early surgery, post-operatively, even though you got a free alternation before surgery, would you advise the patient to continue with occlusion therapy until, suppose you are doing it less than 1 year of age?
To make sure that he is using both eyes is very important, because after you do patching, you are not quite sure whether he is using both eyes binocularly. So this follow-up is very, very important. A 10 prism, vertical 10 prism test is very important. You can see whether he is, I had a video where even the young up to 1 year, you can see the eye moving up and down when you displace the image by keeping a 10 prism base down or up, it doesn't matter. So that movement shows that the child is looking with both eyes. So it's good to follow them up. And of course, until and unless you can see them, look for their vision, visual acuity, binocularity, and stereopsis also, don't leave the patient that they, quite often they feel the eyes are okay. But you have to follow them up. That's very, very important. So this 10 prism base down vertical prism test is a good method to know whether they are using both eyes together. Patching has to be continued. If there was a unilateral dominance, then definitely patching has to be continued.
Madam, in infantile esotropia, maybe after many years, we see a lot of them going for consecutive exotropia. in long-term follow-up? Maybe after 4-5 years when they come back. Do you have any such experience?
Actually, infantile infantile essential esotropia, there are a lot of papers which have shown that they go for exotropia. There is a Chavasi and Park's consensus is not uniform, that there is a central fusion defect. That fusion doesn't occur in congenital esotropes, because even though alignment is okay, and even with the equal vision 6/6, even after some time, the fusion doesn't happen, especially when there is some neurological involvement as well, which we see definitely many cases where they have some periventricular leukomalacia, they have been aligned well, so you don't correct it as well as little esotropia is better, so that they don't go for exo. That is one thing. And is residual esotropia also, you have to follow them up. Dr. Wilson, Edward Wilson, they have published a paper saying that 50% of these essential esotropes, they go for a hypermetropia, and an additional accommodative component also can be there. So you may need glasses during the follow-up. So that is also very important, to give full correction of hypermetropia, which may correct the residual esotropia. So these follow-ups, so it is very important during counseling to make them know that don't think that we are going to give up the glasses by doing surgery, and follow up until and unless they see and read for us, and until the child is cooperative enough. Before 3 years, definitely you don't know how much binocularity he has attained, but you can know from this prism test whether the eye is moving up and down by the vertical movement of the images. So these are some of the methods by which we can know whether binocularity is there. But of course, before 8 months also we can do if there is 100% for same deviation on each visit. There is no harm, but I don't do before 8 months. I don't know what is the general consensus of all of you. I would like to ask all of you. 8 months we plan, definitely between 8 months to 18 months. That is our predict.
Ma'am,
my earliest child for infantile esotropia is 10 months. And at that time I undercorrected like 20-25%, but by 4 years he is ortho and he is having good fusion and all. The patient. For exotropia, usually I overcorrect little. So,
If you are doing a surgery under one infant, it's always better to measure from the limbus, because the eye growth is not complete. We don't measure from the insertion, as we routinely do, because quite often when we plan surgery, it is 8 months and then it goes on to up to 1 year. By the time we see 2-3 times for deviation and make sure that we are going to do surgery, so then it's okay measuring from limbus. But again, if you think the medial rectus is little forward, then you have to measure again and measure from the limbus.
ma'am, if the MR is tight, should we undercorrect lesser?
Actually, essential esotropes, unless it is long standing, you are talking about essential esotropes, isn't it? MR is not that tight, and that is why we do an alternate patching until you do surgery also. And we don't undercorrect, but we have to tell the patient that he may need additional, because we don't know the dosage is perfect or not. But we don't usually see in essential esotropes unless there is a restrictive component or long standing.
Probably when they develop alternate fixation, probably you keep patching, you usually do surgery when they start alternately fixating, so that both are equally being used, and only at that time you go and intervene. Right. So by that time, the strength of the muscles would have been okay. Okay. Ma'am, I would like to ask you, in intermittent exotropias, in less than 3 years with poor control, do you, like as she told you, undercorrect little bit, or
I don't operate usually before 3, and not even 3, 4. That is my cutoff. And but of course, when he goes for a constancy, then we do. We know that he is not fusion even at intermittent fusion means at some points of time he has binocularity, he is fusing, he has some amount of stereopsis, and so it's better not to disrupt that before 4 years. So in early cases before, even after at 4, 5, 6, I don't do an perfect correction. Even under correction is better than over correction, because any over consecutive ESO is going to be amblyogenic. Even if it is under corrected, you can encourage some over minus correction or convergence exercise so that he can accommodative convergence is stimulated. So I don't over correct them, but in adults, yes. In adults, usually it is a postoperative residual what you get, not the overcorrection. So in them, probably that is the maximum deviation you have got during your repeated examinations that you are going to. And even after patching, it's very quite variable because of the tonus of the muscles. Even at the on the day of surgery, they come, they don't let you examine. They fuse, and it's very difficult to dissociate them. So patching and doing the surgery, patching and doing the taking the measurements is good. Even on the day of surgery also, to repeat it is good, because especially I feel before anesthesia they come fasting, so they don't have the potential to fuse. So I do it again on the day of surgery again.
And one more question in acute comitant esotropia post Botox. Post Botox usually takes around few weeks to come. So suppose if we decide that even after Botox the ESO is there, so we need to go in for surgery. How long do you wait after the Botox, and is there any variability of the angle after Botox?
I've seen children well aligned up to 4 months, 5 months, they are okay. But after 6 months, we see a small amount of esotropia. Then I even in a younger children, I try to give a small amount of plus length so that they try to fuse. I wait for at least 3-4 months after they have gone back.
Because I
Not
saw
before.
one post Botox child.
Variable, quite variable.
3 months after post op, it was around 20 prism ESO, and 2 months later, I remeasured. It was approximately 40.
Yeah, they go. It's quite variable. Some of them remain surprisingly, I should say. Some of them remain fused
Do
surprisingly.
you recommend, ma'am, recommend Botox for acute comitant?
Yes, when they come in the acute stage. Yes, before 6 months definitely. We have done up to 6 months, but they do work well before 3 months.
സർജറി ചെയ്യുന്നവർ 6 months വരെ വെയിറ്റ് ചെയ്യില്ല മാഡം ആഫ്റ്റർ ബോട്ടോക്സ്?
After Botox, I think 4-5 months.
It is better to look for variability, as you already pointed out. If you got the measurement 20 prism, 30 prism, 40 prism, until and unless you get 2-3 reading the same as what you had before the Botox, it's better to wait. It's quite variable.
Acute comitant esotropia, they will have this fusional divergence insufficiency also. So as such, they will be little more variable in the initial stages only. So I think before taking up to surgery itself, you have to be little more, get that constant measurement every time. That is what I have felt.
Yeah.
Because usually they'll present like
Actually, doctor, there was a paper from Arvind Eye Hospital which got, Dr. Sandra had published a paper also saying that 88% of them remained ortho after Botox. But I don't know, in my hands it is much, much less.
It is less. I feel.
Even with one dose, it has remained orthophoric.
And they do repeat also. I don't.
Each time taking the child to GA and then repeating and then in.
Which is not very unpredictable. If they have gone back, then I don't see any point in. Already you have waited 3 months after Botox, and then you wait for it to go do a Botox again. I don't know. I don't do it. I have even today I heard some people say Botox, repeat Botox 2-3 times. I don't do. Yes, they do very well with surgery. Yes, many adults up to those who come 15, 16 years with diplopia, they do very well. The diplopia is completely.
I had two sisters, both of them having acute comitant esotropia. And I think 0.5 or points, I gave them plus correction, but they're doing very well after surgery. I think now it is 2.5 years now. They're doing very well with surgery. Botox, but I had this variability. So when I did for 40 also, I counseled the parent that it might increase further. So he might need second surgery and gave a plus after the surgery also.
Yes. I think spectacle correction with either over minus in exo where there is a residual exo, or full correction, or even little more in children with residual ESO. Does work very well. And this, as you said, many family in many families we see hypermetropia, accommodative esotropia. So even if they don't have the accommodative esotropia component, the ciliary, the convergent stone. The convergent stone may be little different. We don't routinely do an AC by A ratio or this for young children. So then that may be a component which is inherited in the family. So that is why probably in children some of the same pattern is being followed by children when we do esotropia correction. Accommodative esotropia, partial accommodative esotropia, we see in the same family so many. So that may be one of the reasons. I think it is inherited probably. Correction, I think, is
I'll ask from here. Madam, in your hands, like over-minusing for intermittent exo, have you come around pseudomyopia? Are you getting?
In fact, I've been using over minus correction since more than say 20 years. And I've not got pseudomyopia. No, they easily give up using myopic correction. That's what I have seen. I thought there are studies saying that they go for myopia also if you give correction.
Yes.
There is a Kushner's paper saying a large series of over minus correction given. None of them after follow-up had myopia. You meant pseudomyopia.
Pseudomyopic shift is coming in these patients.
The usual pattern is they give up by 6 years or so. When they start going to school, the younger age is the one, I think from nowadays we see earlier also. We used to say after 2-3 years, but we do see it for 1.5 years. We give over minus correction. Up to about 4-5 years, they do very well. But after 5 years, they give up wearing glasses. And they should also. I think after that, not the same. So after that, we don't give a correction. I have not seen pseudomyopia in that age, probably because they don't start reading and doing near work for such a long time to produce pseudomyopia. Maybe in the older child, maybe, but I don't, unless they tolerate very well and very happy about it.
Yes.
Some of the children, they go to school late also. So up to 6 years, 7 years it can be. But after that, they don't tolerate like we do give for younger children.
So over-minusing is advised, and we do give for intermittent XTs.
Up to school age, you can definitely give. Not even KG.
Yeah.
Up to 6 years, definitely.
Thank you.
I have given up to 9 years. I have given occasionally, not routine, not all tolerate, but up to 6 years, yes, they do.
I think it may be given till the time they start the orthoptic treatment. They should understand at what age you can start orthoptic treatment. By 4 years at all, we cannot explain to them do these exercises. So at least as a temporary measure to get that functional control for that particular age time, we can use that is what I think.
Actually, this over minus correction is mainly meant for children who have a convergence insufficiency. They do better,
Yes.
but even otherwise they do
Because
universally.
today
That's
I
what we have seen.
I think
Isn't
Dr.
it?
I have also been given over minus, but I have not seen pseudomyopia in those cases, and they do really well.
Yes.
And if the child starts looking over the glass or removing the glass, then fine, we can move on to something else. But by that time, they'll do orthoptic treatment. But younger age, it definitely works.
Yes, definitely
And
works.
maybe
Very relevant point, because the child comes to you, you know she is keeping his spectacle over the nose and he is looking at you over the glasses, then you know he is not compliant.
But I think our population, we see intermittent exotropia more than what we see in these studies. So
There is
I think
a
that
paper
is-
from BJO saying more than 70% of these patients have a myopic stigmatism. So definitely you need to correct them. Along with that, you can give a minus 0.5 or in the older children. They, according to the papers, it can go up to minus 2.5 to 3, which 3 I have not never given.
Thank you, ma'am.
Thank you all for the discussion. I think we all can have a photo.